but just stuff that's going to help you with your season, and then hopefully with your longevity for just being healthy and staying fit. So it's not just going to be a foot-related talk. I think one of the things I wanted to do, especially this year, those of you that were here last year, heard a lot of foot-related stuff, but I'm going to try to bring into also with this talk today a little bit more of the psychological factors and triggers that happen with injury and that happen with not doing what we enjoy doing, which most of us enjoy running. A few of us are here because that was the only camp that was available for this week, but hopefully your mind will change a little bit. All right, so a podiatrist, just like a regular doctor, I just want to explain a little bit about what a podiatrist is. We go to 4 years of college. We have 4 years of grad school like an MD. Here's where it gets different. So in our school program, everything's geared towards the foot and ankle and lower extremity. So vascular as it pertains to the lower extremity. Pathology is like the same pathology classes you would have in a medical school, more or less, maybe a little bit more into the heart and so forth, but we have to cover that as well. I can't really speak to what physical therapy is in the millennium here. When I knew it, it was like, I think you could get you could come out and who knows PT after?
It's a master's program.
A master's.
Yeah, that's all it is.
And then you can get a doctorate if you wanted to do
well, you have to get a
administrative.
doctorate. To practice physical therapy, you have to have a doctorate in physical therapy. So you can have an undergraduate degree in any, biology, chemistry, and then you'd go on and go to a physical therapy program, which I think lasts 2 to 3 years.
Yeah, it's 2 years, and I think you get your I think at a master's level you're able to.
Doctorate in physical therapy.
All right. We're the podiatry now. When I got out, it was a shorter residency. Now they've standardized to 3-year residencies. So 3 years is with foot and ankle. As an MD, you would do 1 year of an internship. Then you would do maybe 2 to 3 years of residency where you would go general surgery if you wanted to be an orthopedic surgeon. And then if you wanted to do, so we'll put like maybe 2 to 3 of residency. And then you would have a 1 or 2, maybe 2-year fellowship. So it's a little bit longer path. The main difference is that with podiatry, you're getting into the foot and ankle and what we do right away. Also, the differences in areas of discipline. An orthopedic surgeon generally isn't going to be treating like a dermatologic problem in the lower extremity, which we do. We see psoriasis, we see poison ivy, we deal with Lyme disease, we deal with different things. Now, we may or may not be the ones to treat it depending on how advanced the Lyme disease, but certainly we're going to assign doxycycline or one of the antibiotics if we feel it needs a specialist that, it's an advanced case of Lyme and it's not just in the prophylactic stages, then we would refer maybe to a rheumatologist. And a rheumatologist deals more with joints, connective tissue problems, and really kind of advanced systemic problems. Now let's get to the problems that you're likely to have here. Just blurt out who has had some kind of either toe problem, knee problem, hip problem, and I just want to hear what they are. All right, in the white shirt. What's your name?
Tyler.
Tyler, what have you had?
I've had a hip problem.
What is it?
I don't know. It was like, I think it was probably like
Hip.
tendonitis.
Hip. So maybe hip tendonitis. All right. I'm going to put that down here. All right, hip tendonitis. All right, that's Tyler. All right, who else? Jack.
I've had IT band issues, tendonitis in my Achilles, and
IT band.
like a nerve in my big toe.
Okay, so you've got about everything. Achilles tendonitis, I'll put Achilles.
And stress fracture.
And multiple
Stress fracture, I'm going to put that down here, stress fracture. We deal with all these issues directly or indirectly. Yep.
Patellar tendonitis.
What is your name?
Cameron.
Cameron's had patellar tendonitis. That is probably going to be number 3 in order of frequency. The difference between patellar tendonitis, has anybody had problems behind the kneecap or around the knee? What?
I had the same thing.
Yeah. But is it center of the knee or just behind the knee? So that, yeah. So if you put your hand around the knee, around the patella, around the kneecap, that is probably the number one injury. That's runner's knee.
Is that iliotibial band syndrome? Is that what that would be? ITB?
It can be related because the ITB comes in here, but it can specifically be, by definition it's more patellofemoral. It's the patellofemoral joint, but ITB insertion plays into runner's knee also. So the iliotibial tract inserts on the outside of the knee.
What does plantar fasciitis fall in there?
That would probably be number 3, behind, in front of. If you look, you look at Runner's World, they're going to have their list, but plantar fasciitis is probably going to be number 3. The top 2 that I've seen are these. Some will put plantar fasciitis ahead of Achilles tendonitis. Achilles is pretty common though with hills and stuff, with cross country. So, although fasciitis is more, we'll see it especially with runners as they get older, and then they start gaining weight. You guys are pretty fit for the most part. Maybe 10 pounds away from your ideal BMI, your body mass index. When I see guys that are, baby boomers, anybody born 1964 or before, up to that generation, and then you got Gen X and millennials and all that stuff. But those people, they, especially when hormones change, you start getting the love handles, and you start adding weight, and then if you can imagine carrying a sack of potatoes, 8 pounds, that's a lot. So now you're running with 8 extra pounds, and that's going to be all directed down through the lower extremity. Okay? Other common things that we see, and I'm just going to mention, would be
Athlete's foot?
athlete's foot. So it's important to keep the feet dry. I mentioned Coolmax socks and wool, smart wool. Those are good things. Changing the socks maybe at mid-practice and not using the same pair of socks. Letting the shoes aerate, taking the insoles out. And then there's different drying agents you can use. And then you'll need an antifungal agent, some kind of cream or powder to put in the shoe. Along with that moisture and humidity, you end up developing, a lot of you may end up developing blisters. So for blisters, the best thing is runner's lube. The best thing is also the moisture management with the socks and with the shoes. If you're wearing, not that any of you are, but if you were wearing all leather shoes during the day, that would not be a good thing for blisters and athlete's foot. All right, so next on my outline was dealing with injury. So we know what sort of the standard stuff has been. We see the ice. I mentioned compression. I think he has a knee issue back there. So compression could be an ace wrap. Compression could also be a knee sleeve. Sometimes that's easier because it doesn't unravel. Elevation is important. Obviously, if you're continuing to participate in practice, that will have to happen after the practice, but you keep it above the level of your heart, the injured body part. And then, of course, rest. So rest is determined by the coach and by you. So it might be walking the route. It might be swimming. It might be cycling. It might be something total low impact. And advanced, I don't know if I doubt they have them here because all this stuff is very expensive, but they even have things where you can do the running motion where you're supported by these buoyancy type balloon things that will take some of the pressure off your girdle. It's like you're in a harness and then you can run on a treadmill and you can have 50% body weight, 60% body weight, 30% body weight. So those are all some of the standard things that we do. We talk a lot about mechanics. I know that Rizzo wanted to hear a little bit about biomechanics, I think. So I'm going to talk a little bit about it. But I think the best way to do this is let's everybody have let's do a half circle here and a half circle here. And just, you can keep your socks on if your socks are already off. We'll form a circle, and then I want to have everybody take their shoes off, and then we're going to we're gonna have half the circle with their backs like this so we can see what the feet look like from behind. And then this half of the circle, which is these guys over here, we'll see. So everybody stand up.
Everybody stand up.
And get in a
Everyone
circle.
Stand up and get over here, and then get over here, standing up. You want us facing the wall or facing
Well, I
you?
want this half first from Coach Mike over facing the TV, and these guys will be facing the television so we can see the back of the.
People in the middle too, or just a
Yeah, no, yeah, just a circle so everybody can see. And we're gonna see what we see first.
Socks off?
Socks off if you want, that's fine. Yeah, you don't have to.
Yeah,
Alright, and just kinda,
I just want to
yeah,
see
get it
feet.
so that you're kind of like in towards the circle so we can see.
but you can leave them
I was all supposed to know.
So Coach Paul has a mild, well, he's actually got, if I'm looking at this line here, can I make a mark? Yes. So if I go mid calcaneus here and through the tendon, he's actually standing in what I call a little bit of verum. I don't want to get too much into this, but what his rear foot is doing is a little bit different than what his forefoot is doing. I call it the too many toes sign. So if I drew a line here, I see 2 toes out, so his forefoot is a little abducted.
So he's rotated out, like.
Yeah, so
rotated?
that's it, yeah, so there's a little bit of this going on, even though this part of the leg is a little bit out to the outside. Yeah, well that,
I want you to look at Connor.
okay, we'll look at. You're pretty good. You're about neutral.
Look at you, man.
Yeah, she got a little bit of abduction, but not bad. That's pretty neutral. And then Coach Mike is pretty good. Coach Mike looks like he's got a little.
You're not good, it's not good.
Yeah, you're just pronated slightly in this side, but not anything right.
It's that breaststroke, man, messing me
Yeah.
up too much.
You roll, man.
There you go.
I can't even see
man.
anything.
One thing I was gonna say though is that a lot of times when I'll see what I call the Fred Flintstone foot, where it's really like
10 to
flat
2.
and out, like
10 to
yeah,
2.
like that, and you'll see the
Barney
toes
Rubble?
way out. I will also see this happen, and that's not happening with Coach Paul. So that's, but I'm gonna see if I can find somebody else. Now here's a good example of somebody that's moderately pronated. So flip to the, turn around just for a second, and.
Oh, yeah.
You see how this is the malleolus, this is the ankle bone. That's kind of not horrible, but it's in a kind of a more downward. It should be ideally like here. So it's casting a little bit dropped, not horribly. So this one more so it looks like.
So pronation is
Yeah.
when the malleus falls in?
Yeah, I don't, if that is pronation, don't worry about the terms, it's more the look. Now, the other thing I want to mention is, you can have that foot and be running perfectly fine.
Mm-hmm.
It's just an indicator that there might be a
You're
problem.
all right, man.
It doesn't necessarily need an arch support. Yeah, you're all right. I want to validate you, you're okay. All right, let's look, all right, so Connor, you want to, and maybe, you know what I will do, because the black socks are throwing me off. Do you want to take the socks off for a second, just so I can see it better?
Oh my god, it smells. Wow.
And then we'll put them on.
You're all right.
All right. So he's got something going on here that's like some bowing on the right in particular. Okay, so that's something that we look at as well. And then what I didn't, well, we're all looking at the feet right now. He's a little bit abducted. He's kind of riding a little bit more of the outside. The feet do look different. This one is more
Rotated out, right?
Yep, rotated out. Sometimes that can be coming through more the torso, the hip. So we don't focus just on the one segment. Do you want to kind of face forward for a second? I just want to see what you look like.
Turn around.
Turn around and face me. Yep. All right, so what I typically do is I'll look at a person. He's got a little bit of a right shoulder drop. Most right-handers are going to be using that and extending more, so that's not uncommon. It can be also coming through the spine. I check the hips. This right hip looks dropped. It might be a little bit projected forward too. Okay, so that can then, there's a lot of things that can happen with hips. Sometimes when you have a shorter segment, and this is probably more than we want to get into too much, but I'll just blurt it out real quick. Sometimes if you have a shorter anatomical segment, let's say you broke your leg and it became shorter for whatever reason. Sometimes you'll project and compensate by rotating the hip. Sometimes it's just due to how your hips congenitally or at birth are set up. So it's set